Okay, so thanks so much for joining me on this call today, guys. My name is Jen Cullen. I am the Business Development Manager for Tekscan, and I'm here with Dr. Ryan Oakley and Dr. Colin Lathrop. Tekscan polled our audiences, and we asked them specifically what type of information related to TScan they would want to learn more about. And one of the things that came up is clear aligner therapy and using TScan as part of that therapy, and also traditional orthodontics as well. So I've got a number of questions. I figure who better to get online than Colin and Ryan. They are both members of the Academy of Clear Aligners and top Invisalign providers in their area, and just amazing dentists in general and super cool guys. So yeah, to start off, just besides being some of the coolest guys in dentistry that I know, why don't you guys just tell us a little bit about yourselves?
Go, Colin.
Well, I've been a TScan user for several years. General dentist, I have a very large practice in Katy, Texas, scratch start 2013, all high tech, and we pretty much do just about everything. And always looking to differentiate our practice and just provide better treatment services, quality, explanation, education, all those things for our patient base, for our team, and for the doctors that come through and kind of see how we run things and that sort of stuff. So it works out really well. And TScan has been a great partner in a lot of high-end therapy, as far as full mouth reconstruction all the way down to just basic, simple aligner cases. So you can't really go wrong with it.
Great.
Awesome. My name is Ryan Oakley. I'm a general dentist in the Houston area also. Houston's a big place, so Colin and I are both sort of in Houston, but we're probably like an hour and 20 minutes away from each other.
Yeah.
I've been a TScan owner for a long time. I've been a TScan aficionado for pushing a year now, thanks to Colin. And it's kind of similar practice size. I'm part of a big group practice, and once again, also high tech and trying to provide the best care for patients. And TScan is something where, for me, more than anything, the understanding of occlusion has been something that I've kind of chased for as long as I've been in dentistry, and really understanding how to use the TScan has taken something for me that's always been sort of something I was always trying to learn and figure out and just could never quite understand, to something that I am now exceedingly comfortable treating, providing, and explaining to people. So it's been, when it comes to occlusion, TScan's kind of like, a silver bullet, so to speak, as far as your understanding and then implementation and follow through.
Cool. Yeah, I appreciate it.
You're welcome, Ryan.
Yes, and the reason I went from a TScan owner to a TScan user is because of Colin's influence. So
thanks, Colin.
I owe him.
We all
I have to
appreciate
send
it.
him
The world is
royalty
better
checks
disease.
for everything I do in dentistry now.
I'll take 'em.
Great. So yeah, why don't you guys, that obviously describes my next question, is around how you first became interested in the technology. Maybe you can both kind of just touch on that quickly.
Yeah, I'll do that first. I had heard about the TScan probably 12 years ago, if not longer than that, from Bruce Baird of the Productive Dentist Academy. Bruce Baird has been a big proponent of the TScan for as long as I can remember, and would speak about TScan at the productivity workshop. And they also typically had a TScan rep there at the productivity workshops, and they may still do. So I'd heard about it forever, and then I got it, and I sort of dabbled with it. It spent most of its time in a drawer, and I'd pull it out every once in a while. I'd pull it out and try to get into it, and never really never really took
But
off
if you're
for
not
me.
using it, it's hard to really see the value, right?
And then I had gotten it out, and I was trying to make it work, and I'm hanging out with Colin, and Colin's the one that opened my eyes to the possibilities with it.
Cool.
And Colin's the one that turned me on to Dr. Kirstein and Dr. Sutter. And it was after doing training with Robert and Ben that things really took off for me with it.
Cool. How about you, Colin?
You know, I read about TScan way back when I was in dental school. And my periodontist that I was referring to in Sugar Land, which is maybe 40 minutes away, he had been using it for a long time. And, you know, so I'd always had the exposure to it, knew about it. And after I opened my practice, I really wanted to incorporate that. And one of the C programs that I had taken was at Arrowhead Lab out in Utah. Jim Downs teaches the full arch and occlusion courses out there. And I had taken the full arch course, and that's where I finally bought the T-Scan when I was there. And that was 4 or 5 years ago or something like that. But I've known about it for a really long time, and I just could not believe that more people didn't use it.
Yeah.
And a lot of people that I had talked to about it, they're like, "Oh, I don't need that, you know, really expensive marking paper and all this other stuff." And the more that I understand it, the more that I've used it, the more training that I've gotten, the more cases that I have saved because of it. I think, man, you know, you people, you will spend $150,000 on a cone beam, $100,000 on a laser, you know, all this other stuff, and you would use a T-Scan every day. On everyday dentistry, and it would make a bigger impact, you know, on what you're doing, whether it's full arch or just a single, you know, MOD on a lower molar or something like that. It doesn't matter. So yeah, it's been a while.
Well, we appreciate that. I love the shout outs to Dr. Bruce Baird and Dr. Jim Downs. I've worked with them both individually for a long time, as have a lot of people on our team, and they've just been super supportive, and they provide such awesome education to dentists as well. So yeah, I love that.
Hey, Jen, I think Colin hit on something really important there, and this may be skipping to further questions, but people always want to talk about ROI with different things, and, you know, what do you this and that. What Colin just said is how many cases he saved using the T-Scan. And
that's a good way to
I'm not sure what kind of Dentrix report you can run to show that kind of stuff, but that really is at the heart of what you're able to do using the T-Scan is you're able to prevent failures. And that is something not only financially, but just psychologically that is hard to put a price on. It's a big deal knowing that you've prevented problems.
Totally. All right, so I'm going to shift gears just a little bit and jump into a couple of clinical questions. We get these questions pretty often, and so I thought it was best to kind of have you guys run through, kind of give you a scenario. So let's say that a patient comes in and you identify that they have an occlusal issue. Tell me about how you're going to go about communicating to them their problems, or how you might introduce clear aligner therapy to them. What does that conversation kind of look like?
Me to go?
I'll go first on this one, if you don't mind, Ryan.
Yeah.
So a lot of times, you know, one of my hygienists will recognize that there's a malocclusion issue, abfraction, sensitivity, you know, cracked teeth, whatever indication that we would use clear aligners, whether it's in-house ortho made aligners or Invisalign is my usual number one go-to. And so basically, I know you can show patients the data and all this other stuff, but that's like showing patients an X-ray. They're not a radiologist. You can't say, well, there's your cavity right there. You see it? And they're like nodding their head. They don't know what you're talking about. So I try to break it down in really simple terms. I try to talk to my patients as if they're a senior in high school. And that way I cover pretty much my whole patient base, no matter who they are. And I'll talk to them about the balance of the bite. I'll say, you know, when you bite down, you're like 90% on your right side. If you walked around and you had 90% of your weight on your right foot or your right knee, you'd probably need a knee replacement not too long. If you drove around and your tires were, you know, not aligned correctly, and it was pulling you over into the wall of the freeway every time, you burn through tires every 3 or 4 months. It gets really expensive. It's the same thing on your bite. I use those kind of two basic analogies because most people have either heard of someone or have a family member that's had a knee replacement, and it sounds awful and expensive, or most people who are above driving age and own their own vehicle have replaced tires in their car. They don't really like doing that or want to do it again. And so that's helpful. And the other thing is, now I had taken Robert and Ben's DTR training course, so I have patients go through the excursive movements with a T-scan, and I'm looking to see all of the posterior occlusion garbage that they have, and I'm using that information and I'm translating that into my little pea brain and saying, I bet you have headaches, don't you? And they're like, yeah, I do. And your muscles over here are pretty sore, aren't they? And I'll palpate the muscles for them. They're like, yeah, they are. I said, well, what the data is telling me is that your bite doesn't really fit well, and it's causing these other symptoms of discomfort or pain or sensitivity or these other things that you have. You can either spend a lot of money over the next 10, 15, 20 years, fixing all your teeth, $40, $50, $60,000 in a full mouth reconstruction by the time you're 55 to 65, or we can straighten the teeth, balance the bite,
fix it now.
Kind of like balancing your tires and aligning your tires so you're not having to, replace them all the time.
Right.
And then they're your own teeth. I think that's a better, smarter way to go, especially at whatever the price is, for their case.
Yeah. Totally.
Because, then they're thinking, they're hearing $50,000, $60,000 in dental work. And then you come in at the bargain basement price of $5,800 or whatever it is for a full course of Invisalign, with retainers at the end. Then I do 6 to 8 months after Invisalign, I will go back in with a T-scan and I will check the occlusion, make adjustments as needed, to try to keep them stable, keep the case stable, keep them comfortable. So that little spiel has done very well in getting patients who we had talked to about orthodontics before, more of a cosmetic treatment. And they're like, yeah, I'm good. I'm fine. I'm married. I got kids.
Right.
I'm not looking to impress anybody, blah, 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 blah.
I don't need to spend that money on myself. Right.
Yeah. And especially it's really effective after you have put a crown on one of their teeth. I said, if you want to keep doing that, it's cool. I'll keep taking your money to fix those teeth. But if you straighten them all, we won't have to really do that very much. And it's a lot healthier way for you, to keep your own teeth for a lifetime. And a lot of times, right then and there, it's either after a breakage, they'll sign up for it, or during hygiene, we'll go through the balance issue and all that other stuff.
Cool. Ryan, you want to add to that?
Yeah, absolutely. I mean, it's hard to top. We could do like a recording just of Colin's communication stuff, because he has like he totally has every time
I just picked up like 10 pearls. I was like, that's awesome.
Every time I talk to Colin, I'm like, give me a piece of paper so I can write this stuff down.
Yeah.
I think the important takeaway from what Colin said comes back to what I do in practice also, is that in what he said, he didn't have something that just magically makes something happen. He has a dialogue with the patient and meets them where they're at, right?
Totally.
And the reason Colin can have a dialogue, like he said, is not because he has something cool, something cute to say or cool to say or some kind of verbiage. He can have a dialogue because he has an understanding of occlusion. He's able to look at the patient and he knows the cause and effect, and that allows him to have the proper kind of dialogue that's backed by his confidence and understanding, because he knows what's going on. And I think that's where I used to not be and where I am now, from, like he said, taking Ben and Robert's course and from using the T-scan and understanding, is when you see the signs and symptoms of malocclusion in someone's mouth, you know what it takes to, what the consequences are, what it takes to get them in a place of stability. And then you're able to have the proper dialogue from the patient standpoint, like Colin said, showing them a fancy graph or showing them this or that and the other. That isn't what moves a patient or shows confidence in you. It's the way that you're speaking about it, and it's the way you're able to explain things simply and concisely. But you're not able to do that until you have that understanding of what's going on.
Right. Very cool. So if we take that a little bit further, so the patient accepts the aligner treatment, and Colin, you kind of touched on this a little bit, but I'd like to hear a little bit more about like your protocol and for your aligner therapy. Like at what points during that process, I know Colin, you said you're using it 6 to 8 months post aligner therapy. Ryan, we had talked about how you were doing a check mid aligner therapy. Maybe you guys can just touch on that briefly. Where are the places where TScan would be used in that process?
Gotcha. I'll go first on this one. So with any case, there is a beginning and a middle and an end, right? In the beginning, you may be using TScan to verify that the signs or what you're seeing on their teeth, whether that's recession, abfractions, fracture lines on teeth, or their symptoms, muscle pain, cold sensitivity, etc., are occlusal based, right? So you see visually with your eyes, and then TScan can confirm that they're having a long disclusion time or they're imbalanced on the right and left side or whatever, right? In the middle, you may be just doing progress assessment, right? So you may be using the TScan to just verify as you're going through the process or midway or whenever you choose, or before you're going to either finish the Invisalign therapy or deband with ortho, to make sure that you're getting where you want to be. Right. Whether you need to then modify what you're doing or just be aware of what you're going to need to do as far as adjustments go once the case is finished. And then at the end, to then finish the case, right? You've gotten to a certain place. You're never going to be perfect with regular orthodontics. You're never going to have a perfect bite after Invisalign. I don't know if there's any studies on it, Colin, with Invisalign, but there's studies that show that most class 1 patients treated with regular orthodontics, something like 70% of them are overloaded on their second molars, right? So they've shown that after orthodontic therapy, people have more force outliers than if they weren't treated orthodontically, right? So when it comes to finishing the case, you're using it to then just fine tune what you did and actually have an occlusion that's balanced on the right and left side, doesn't have any force outliers, and that the patient has canine guidance. Colin does it 6 to 8 months afterward. I think that 6 to 8 months is a good general rule. I think it kind of comes down to when you're typically doing your retainer checks post-operatively too, or when you finish a case too. If I have a patient that we did ortho on due to muscular TMD symptoms, I'm probably checking them on the TScan sooner than that. And Colin, you may be doing that. If that was the purpose of it, I'm probably doing that immediately after we finish the case. But I don't know. That answer the question?
Yeah, absolutely.
Clean that up, Colin.
So I'll take a TScan before, either before we start their case or at delivery of their Invisalign case. We'll take a TScan record that day. Some people, just for data collection, I'm also taking a TScan record immediately after we have delivered all the attachments and the aligners. So what we'll do is we'll take a baseline scan, aligners out, document everything, and then I'll have them put their aligners in, and I'll take another scan to see what the reduction in the overall force is, because you'll see in your force graph, that it goes down. You can't clench as much, especially with anterior bite ramps on these Invisalign trays. After the case is finished, a lot of times when we put them in their final holding retainers, I'll take another TScan measurement. I'm not doing any adjustments then, just to kind of see where they are, and I'll compare where they started and then where they finished with the with Invisalign therapy. I am looking into taking STL scans of all the arches beforehand and then overlaying with all the TScan data. It's one of my projects to work on. I got more time now, so I can get going on that. But if they're a regular patient, there's no pain or there's no crazy things, then 6 to 8 months later. Otherwise, I will make if they are a pain patient, like what Ryan was talking about, TMD symptoms, Then I will T-scan them when we're finished. I will do a DTR style adjustment and put them in their final holding retainers. I'll see them 3 months later. I'll see them 6 months later. And then after that, what we're doing now is we're taking T-scan records a year, 18 months after, and comparing those with the original data for those cases that we were consistent with taking them on. So we're still getting consistent with our protocol for aligner therapy with Invisalign, scanning, T-scan, scanning, all of that stuff together, so that we can get a really good protocol and be very consistent, so that then I can kind of comb through all of that data and then share that with some other people, or even publish some of this stuff in the future. But we try to scan them as much as possible, especially to help guide our treatment to see, do we need to make more changes or not?
Right.
So
cool. That helps a ton. So for people that aren't using T-scan now, like what is maybe point out one or two things that T-scan gives you during that aligner therapy that you don't get if you're not using the technology.
Go ahead.
Anterior contacts. That's the biggest use of the T-scan during active aligner therapy or even fixed orthotherapy. So everything looks great, and then they take all the buttons off, they put them in retainers and all that sort of stuff. And then 2 or 3 weeks later, the patient comes in and they've got a space somewhere in the front on the upper. And you're like, oh man, I guess I'll have to do a refinement and scan you and put you in Invisalign all over again. And then you do that again, and then you finish. 2 or 3 months later, they come back in, and it's more spacing that occurs later on. Because yes, you can check your anterior contacts with marking paper if it will show up, but it will not give you the direction of force when they're going into the excursive movements. Right. And so most people are checking on a regular MI bite. They don't see contacts there, and they're like, this is great, let's put them in retainers. But what happens is, if you don't check them in the excursive movements, you're not going to see that those cuspids are pushing that lateral out, right. Or you're overloading something to where you're creating a diastema just during normal chewing function. And right. That's where the relapses, especially in the anterior, will come from. That's the biggest thing, because most users that are not using a T-scan and they're relying solely on 100-year-old technology with marking paper, they're missing out on that. They're creating a lot more retreatments for themselves. They're creating extended treatment times with their patients. And let's be honest, if you've done enough ortho or long-term treatment on people, patients develop dental fatigue. They just get tired of it. They don't want to do it anymore. And they're like, you know what? I don't care. I've got a space. It's fine. And then they move, and 2 or 3 years later, they forgot that conversation. They forgot their fatigue. And then their new dentist is like, we got a space here. And they say, well, I did Invisalign. And the new dentist says, oh, you had a bad dentist. He did an awful case for you. You should sue him.
And that's
or some garbage like that.
Right,
exactly. So using the technology that way has been way better.
Cool. Yeah, I love that perspective.
Yeah.
Right.
I think that one of the biggest things for me is there's a lot of talk about treating malocclusion with Invisalign, right? Most people have had their Invisalign rep come give a lunch and learn to their hygienist about evaluating malocclusion and talking to patients about treating malocclusion. And what you don't know without using a T-scan is that just lining the teeth up doesn't necessarily fix a malocclusion, and it doesn't necessarily it could even make the situation worse as far as the signs and symptoms that it's generating. And so when you line the teeth up, and a lot of times we do expansion in the premolar area, which leads to more of a tipping in the premolar area that actually brings the lingual cusp of the upper premolars into more of a contact than they should be. And so when you align teeth, a lot of times you are creating more of a group function than they might have even had to begin with, right? And so you talk to a patient about their signs and symptoms and about how you're going to treat their malocclusion with orthodontics or Invisalign, and you don't necessarily treat the problem. You just line up teeth more, and you might even create more of a group function issue through your therapy. So understanding occlusion and using a T-scan to verify your results and then make adjustments allows you to kind of put your money where your mouth is if you are speaking to patients about malocclusion in the chair.
Cool. Yeah, that's
Agreed.
I love those that perspective. I think that's like exactly what people are interested in hearing too, right? Is what is it that it's doing to sort of solve a problem of some sort. Okay, so before I let you guys go, just one last question for the benefit of all the doctors that are going to be listening to this. What's just one pearl that you could leave the audience with for the doctors listening? And it doesn't have to be T-scan related. I'm not all about T-scan too. I mean, we can veer from that if we need to.
Ooh, you just opened it up.
I know. Maybe I should.
All right, I'll give a pearl. I'll give my favorite pearl, non-T-scan, and I'll give a T-scan pearl. Got it. So number one pearl that I could recommend to anybody is to make post-up calls or texts to your patients that you treat. Anybody that you numb up. I used to do it. I used to make phone calls. I've been making them for, pushing 20 years now. I think it's one of the most powerful relationship builders and practice builders. So often you'll hear people say, I had a guy that was like 90 and he's like, I've been going to doctors my whole life and you're the first person that ever called to check on me. Do follow-up calls with your patients. I used to do calls. I decided to do an experiment. I would call, let's say I had 10 people to call. Maybe one person would pick up, maybe one person would call back and like leave me a voicemail. But when I see the patients, they don't tell me they appreciated the call. I started texting patients. It takes way less time. I usually hear back from like 90% of them saying, thank you. I really appreciate you checking up on me. But make follow-up calls. Make follow-up calls. It's very, very important.
You could add to it and you could say, make follow-up calls so they have to come in and get their T-scan done. And then, T-scan pearl all of a sudden.
With T-scan, though, it kind of goes back to what Colin said in the beginning. So many of our failures are from our misinterpretation of occlusal issues. You will save yourself so much headache and heartache if you are able to properly address occlusal issues that a lot of times we cause.
Right. That's awesome. Colin?
I will start with a T-scan pearl. T-scan all of your implant crowns several times over. Cool. Because there's nothing that's going to show you more as far as force issues. And if you T-scan your patient before you screw in or cement your crown, get your baseline, and then add your implant crown and see what has changed as far as your disclusion time or your force direction, your balance, any of those things. Cool. So take a baseline and then load your implant crown and then scan them again and then adjust your implant crown until you get back to your previous scan data. That's cool.
We might need to do a whole other conversation on implant stuff, right?
Hey, that's easy. As far as non-dental or a non-T-scan, but general dental pearl, you got to figure out, and I'm going to go back to Jim Downs on this one. Big change in my practice. When I started thinking about and expressing in simple terms to all of our patients consistently so that my team could hear the same message over and over, and for my patients to hear the same message over and over, is I would tell people, I don't want to drill in your teeth if I don't have to. Of course, they don't want you to do that either. And so that opens up a lot more treatment as far as ortho or all these other things. But the reason I tell them that is I say, listen, I'm trying to figure out what is the best plan for you so that when you're 90, 95, 100, 105, whatever age you are when you expire, you're still going to have as many of your own teeth as possible and they're going to look good and function really well. So developing a true lifetime plan for patients is far better for them, for your ethics and all these other things, than just looking at what can you drill on today to get payment out of a patient as quickly as possible, that sort of stuff. Because if you think comprehensively and shoot for that, then that's going to open up way more dentistry over a longer period of time. And it's better for your patients, and they're going to feel that you're doing it in their best interests. And you want to talk about driving referrals. when patients have an overwhelming amount of trust in you, and they know that you're looking out for them, you're investing in all this technology and all these, CE courses and all this other stuff to provide the best things for them, then they're going to refer more and more and more people to you, because they've already had either other dentists that are trying to get their money out of their pocket quickly, or with all the corporate dental offices that are coming in, there's just a big changing wave of how we look at dentistry, and then the results of all this pandemic stuff, how that's going to change private practice, but nothing changes how you feel about a patient and what you recommend to them. So, and
Totally.
that will pay the biggest dividends.
I love that. Awesome. Thank you both so much. We really appreciate it. I loved chatting with you guys and just seeing your faces, right? We have to have this face-to-face interaction more. So yeah, thank you again. And for everybody that's watching, stay tuned. We'll have more interviews coming. And yeah, we appreciate your time. Hope everybody stays safe and healthy.
Awesome. Jen, thanks for having us. I feel like I got more out of this listening to Colin than anybody can just being on here.
Right. Me too.
Yeah,
Me too. Both of you. I love it. It's really great. So
I love teeth and I'm missing them right now. So, whatever we can do to help.